و O2 hemoglobin dissociation curve. IV fluids. شو بتعرفوا IV fluids؟
saline.
Saline. Danger
Normal
solution.
saline.
Danger solution.
Ringer saline. Ringer lactate.
Yes.
TP.
فيل اللي بالجلوكوز ها.
Hyperkalemic. Hyperkalemic مش hyperkalemic. Hypertonic. انت حكيت hypertonic انا سمعت غلط انا اسف حقك علي. Hypertonic saline تمام. Generally بنقسمهم نوعين either crystalloids or colloids. Both of them doesn't have any oxygen carrying capacity لأنه الجهتين ما فيهم cells اللي هي RBCs فبالتالي ما في hemoglobin فبالتالي ما في oxygen carrying هذا رح نحكي عنه شوي بالاكسجين hemoglobin dissociation curve فبالتالي هي just fluids. Crystalloids ones هو اللي احنا most commonly we use it cheap available very quick. One of its problem that it distributes within the extracellular fluid, which means 75% will remain will stay in the interstitial space, and only 25% will stay within the intravascular space. Which means if you give it to manage hypotension, it's not enough. You need to replace each ml lost with 3 mL of crystalloid fluid, which might result in some populations, some patients that might not tolerate very high volumes of fluid to fluid overload. So you need to watch out for that as well. Any patient, in theaters, we calculate how much blood is lost, so we can assess how much the hemoglobin for the patient will be afterwards, and if they need, we assess if they need to be transfused or not. If it's simple, just like 50 cc, we just replace it with another 150 cc of any crystalloid fluid, that'd be fine. The problem would be with higher volumes of fluid, and if the blood product is available or not, and if we need to go for blood products, or we need to go for colloids afterwards. Crystalloid fluids. Now this schedule is actually a very common question, whether in the surgical exams, whether OSCE or written ones. They will ask you about the content of each one of these and about their osmolality. Now, we have isotonic solutions. This is the extracellular fluid, and these are the usual normal ranges that we expect in our bodies. And this is the range that we accept as isotonic. Hence, we accept as the Ringer lactate and the normal saline 0.9% to be isotonic. The rest can be either hypo or hypertonic. Plasmaloid is a mix of human plasma with some electrolytes. The rest are just fluids that we use for variant causes. Isotonic salines, as I mentioned, we use almost always isotonic salines. There's very specific indications for the use of hypotonic or hypertonic. Hypertonic ones, we have the hypertonic saline. It's most commonly used with severe hyponatremia and treating neurological symptoms associated with it, such as seizures. This is the very specific indication. Sometimes it's given as a nebulizer for the secretions in the respiratory system in case of infection, especially in children. In cases of overload, but you need to give someone who's hyponatremic but already fluid overloaded, so you need to provide some sodium with very small amounts. So this is a good option. Cerebral edema. Now, if you give an isotonic saline, it will be the same osmolality as within the cells, which means that the fluid shifts will be minimal to reach the equilibrium. On the other hand, if you give a hypotonic solution, the fluid will start going from by osmosis, the water will start flowing into the cells, which means that your cells will gonna swell. If you give hypertonic fluid, the cells will start shrinking because the fluid will start moving out of the cells. So you need to watch out for that. In cases of cerebral edema, that's exactly what we want. We want to withdraw the fluid from the cells so we can give either hypertonic saline. Sometimes we use mannitol for the same thing, with the same idea. Maintenance fluid, blood loss, burns, sepsis, anaphylaxis, dehydration, hypovolemia. We all of it, we use isotonic solutions. We use the most physiological ones most commonly, which is,
No,
No.
ECF.
can you guess which is the most physiological one?
Plasma
Normal sound.
Ringer lactate.
light.
Ringer lactate is always available. It has the, mostly, just like us, the same as our electrolytes. Plasma is very close, but it's not always available. So we go with ringer lactate. These numbers is required from you to know. Colloid infusions. What's the difference between the colloids and the crystalloids? Anyone?
Proteins, دكتورة.
Proteins. Good. But some of them are non-protein solutions. They have dextrans and starches. اللي هم الهس الهس الموست common one. في منه الفولفين والبان سرطان. Pantaspan. So we have these. The colloids have higher molecular weight substances, which means that they will remain intravascularly because these substances will increase the osmolarity, preventing the fluid or the water shifting from intravascular to the interstitial space or into the cells. It could be protein colloids, such as the albumin and the gelatin solutions, or non-proteins, such as His, which is most commonly used. The ratio of infiltration, 1:1, unlike the crystalloids, 3:1. It's all experimental. The problem of colloids, as any other thing that we give, there's nothing without side effects. So there's very risk of renal side effects and there is coagulopathic side effects. So there's nothing without the risk. These are types of His solutions, which is Volvin and Pantaspan. It's different within the concentration. When do we use colloids? We have severe hypovolemia. When we have severe hypovolemia, crystalloids are not enough. Blood products is not ready or not available. This will give you a few hours before you get help or you get some blood products. The only problem is that you need to keep an eye on their oxygen levels because their oxygen carrying capacity, they don't have any oxygen carrying capacity and the oxygen content within the blood will be going down and down. Adverse effects of colloids, volume overload, impairment of platelet aggregation, anaphylactic reactions, and nephrotoxicity. This is just a comparison between the advantages and disadvantages of crystalloids and colloids. Crystalloids, as we said, cheap, non-allergic, no interference with coagulation, no transmission of infections. Disadvantages, higher volume needed, relatively short amount of time remaining intravascularly. The rest, 75%, will shift in the interstitial space. Colloids, expansion of the plasma volume is far superior, maybe salt sparing, unlike the crystalloids. Expensive, risk of allergy, renal dysfunction, coagulopathy, itching, and may exacerbate tissue edema. Any question? No? We're good?
بس دكتورة شو أهم الانديكيشن اللي بنعطي فيهم الكلويد؟
Colloid? أهم indication?
Severe hypovolemia.
Sometimes you have a hypovolemic patient or you don't have blood products. This will save you, this will support the blood pressure of the patient until you get some blood products. This is the main indication. You cannot give too much crystalloids because most of it will go interstitially and it will cause edema, peripheral edema, rather than with more and more hypotension. So after a little bit of time, you cannot give anymore. As for normal saline, too much of normal saline will cause hyperkalemic metabolic acidosis. So most of the anesthetists prefer to give maximum of 1 liter, 1.5 liter of normal saline, and then they would go for a ringer lactate. You have to keep in mind that you need a little bit of oxygen carrying capacity, and you need to give a little bit of colloids if you don't have any blood. So you should have a plan in mind if you have a patient bleeding in front of you. So it's just for bridging rather than it's a definitive treatment. Blood transfusion. Okay. We used to give whole blood in the old days. Now we don't. We just give the necessary component of the blood. Either RPCs, fresh frozen plasma, platelets, cryoprecipitate. We can use also plasma derivatives, which can be albumin or coagulation factors concentrates, or immunoglobulins specifically. Clinical transfusions. Why do we transfuse our patients? Blood loss. To restore blood volume. Coagulopathies. With coagulopathies, the patient will lose many of their clotting factors, so maybe to replace that. True. To replace platelets, coagulation factors, or plasma proteins. And the last one, the oxygen capacity by giving red blood cells. Blood may be needed in cases of trauma or bleeding, inadequate production, such as cases of leukemia or thalassemia, or excessive destruction, whether intravascularly or extravascularly, whether it's mechanical valves or with some diseases. As I mentioned, whole blood is not used anymore, at least not very commonly, because it carries an infection risk. It needs to be stored between 2 to 6 degrees. Indications, replacement for the whole blood loss or exchange transfusion. Contraindications, it will cause a severe volume overload for patients who doesn't tolerate it. Chronic anemia and cardiac failure. Packed RPCs. Each unit of the packed RPCs has a hematocrit of 60%. It should elevate the patient's hematocrit to 3%. Carries the small risk of infection as the whole blood. Indications, anemic patients, whatever the causes. Whether to blood loss, whether to bleeding, diseases, more destruction. Platelets. Platelets, we now found multi-donor pools. This is the most common one, and these are cheaper to produce. They still carry a bacterial contamination effect. Indications of treatment, it's different. Some would delay the treatment of the platelets till the end, that they don't have any other resources, because you need to manage the underlying cause first. And this is where the contraindications come from. Idiopathic autoimmune thrombocytopenic purpura, ITP, because once you give it, if you didn't give any immunosuppressants beforehand, all the pool will be destructed within less than an hour, so it will be pointless. You need to manage that with an immune suppressant first, and then you can consider if you need to give more or not. Patients with high risk of arterial thrombi and MIs with TTP, contraindicated. Untreated DIC, you have to manage the source of the DIC first, and thrombocytopenia with septicemia and hypersalinism. Treat the underlying cause first. Indications, thrombocytopenia, platelet function defects. So we have a good number, but dysfunctioning. Prevention of bleeding due to thrombocytopenia, as in bone marrow failure. Bone marrow failure, you'll have less and less numbers. Fresh frozen plasma, prepared from the whole blood. Platelets. is stored at room temperatures, which increases the risk of infection. Fresh frozen plasma should be stored within 8 hours of collection, immediately rapidly frozen to minus 25 degrees, and once needed, it can be thawed. Because it's rapidly frozen at these temperatures, it can last up to 1 year to be used. Once we need to use it, we just thaw it to temperatures between 30 and 37. Capable of transmitting any agent present in cells or plasma which is undetected. It should be acellular, so unless it was missed, but plasma should be acellular, shouldn't have any cells containing any of these infections. Why do we give it? Because it will have stable levels of clotting factors, albumin, immunoglobulin, and factor VIII. Other indications. Replacement of a single coagulation factor. Either it is an inherited or an acquired deficiency for whatever cause. Most of them are inherited. To replace it for a single indication or a single procedure. Sometimes before procedures, patients, we just give them this as a top-up to prevent bleeding for this procedure, and then they can continue afterwards without any. Immediate reversal of warfarin effect, where prothrombin complex concentrate is unavailable. So our first go with warfarin toxicity is prothrombin complex. If it's not available, we would give FFP. Mind that we can't give too much volume for some patients. We can't overload them. So you have to balance at this point. TTP, inherited coagulation inhibitor deficiencies, and C1 esterase deficiencies. Conditional indications, acute DIC if there are coagulation abnormalities and the patient is bleeding. Do you know what the DIC is?
Disseminated intravascular
Coagulation.
What happens with it?
destruction أو thrombosis بالmicrovascular.
Yes, it happens intravascularly.
Yeah.
So there is clots forming, consuming all the clotting agents, all the clotting factors, enhancing bleeding tendency. So at the same time, there's clotting happening and there's bleeding tendency. One of the management is FFP. Liver diseases with abnormal coagulation bleeding. All the clotting factors are produced within the liver except
إيش هو السؤال؟
8. All the clotting factors is produced by the liver except
8 endothelia.
Yes. Cardiopulmonary bypass surgery, it's cardiac surgery using cardiopulmonary bypass. Do you know what a cardiopulmonary bypass is? It's basically a machine that we connect patients to during cardiac surgery that will perform from its name the job of your heart and respiratory system. So it takes all the blood, it's connected to one vein and then one artery, takes all the blood from the vein, gets oxygenated and returned to the body with high pressure to be enough to be distributed to the whole body. When we use it, we need to give our patients anticoagulants. Usually we give heparin, very high dose of heparin, to prevent clots forming once the blood hits the machine. So once we get the whole blood back to our patients, we need to reverse the work of the heparin. We have an antidote, but if their patients are still bleeding, we can give FFP. Severe sepsis. Severe sepsis, particularly in neonate, independent of DIC. Independent of DIC, which means that it doesn't involve clotting factors, but sometimes sepsis, they need a little bit of support without a DIC happening. Plasmapheresis and massive blood transfusion. Part of a massive blood transfusion, anyone knows what the definition of massive blood transfusion? Either changing half of the blood within 4 hours, some resources says half of the blood within 1 hour, or changing the whole blood within 24 hours. An indication, or by definition, massive blood transfusion should be 1 to 1 to 1, packed RBCs, FFP, and platelets. Otherwise, you'll have dilution in your clotting factors, and you will have bleeding tendency. Cryoprecipitate, antihemophilic factor. We give it to patients either with 4 the fibrinogen, factor 8, von Willebrand deficiencies, or factor 13. Storage, such as the FFP, minus 25, colder up to 1 year. Indications, hemophilia A, von Willebrand deficiencies, as another source of fibrinogen in acquired coagulopathies, and isolated factor 13 deficiency. Severe reactions, most commonly present during the first 15 minutes. Severe ones. Especially if your patient is anesthetized, you need to pay extra attention because they cannot mention what they're feeling. So all patients should be monitored during this period and act subsequently if there is anything happening. أي سؤال لهون؟ Complications of blood transfusions. We have infectious ones, which is very obvious, either viral, bacterial, or parasitic, or immune ones, which the ones that we're going to talk about today. Most common complications after blood transfusion? Febrile non-hemolytic reactions. This is the most common one. Most serious ones? ABO incompatibility hemolytic reactions.
الكروس ماتش هذا دكتور؟ كروس ماتشنج
Cross matching, yes. الفبرايل ones no, بس ال ABO. Most common, as I said, febrile non-hemolytic ones. Most serious are ABO incompatibility. It has a very high mortality, as well as the transfusion-related acute lung injury. Hemolytic reactions. Specific destruction of the transfused cells, mostly due to antibodies. What do we do if that happens? You had a patient, he had a reaction. What do we do? You suspect that it's an ABO incompatibility.
بنوقف إنه نعطي.
بنوقف. كثير بكير.
بلازما فريسس.
كثير بكير. Steps ABCs. وقفنا البلد، عم نعطي بلد شكينا انه هذا في ABO incompatibility. What's next? يلا. أول إشي بنوقف الترانسفيوجن. We notify the blood bank. We resend the blood and we take blood samples from the patient to make sure that they are compatible or not compatible. And then we act ABCs with to make sure that they are breathing okay, blood pressure and heart rate is fine, oxygen saturation is okay, ABCs. And then we insert urinary bladder catheters to monitor if there is any hemoglobin within. If there is suspected that there is an ABO compatibility confirmed, you need to do diuresis. Symptoms, how do they present? How would you know? A rise in our temperature, unexplained tachycardia, hypotension, hemoglobinuria, oozing in the surgical field, DIC, shock, and kidney failure usually happen a little bit later, can develop rapidly, but not immediately within the event. You need to make sure that your patient is not misidentified. When you get a blood bag or an RBC bag, match it against the blood slip, match it against your patient bracelet identification. Make sure that there isn't any leaks, any clots, and it's not expired. These are the things that you need to check with every transfusion. Hemolytic reactions are commonly classified either as acute intravascular or delayed extravascular. Delayed extravascular, where does it happen? Spleen, and might happen in the liver as well. These are the ones usually due to non-D antigens, the delayed hemolytic reactions. KIL, Duffy, or KID antigens, and usually happens are delayed from 2 to 21 days. They might present with consisting malaise, jaundice, and fever, with hematocrit typically failing to rise after transfusion. Other non-hemolytic immune reactions, febrile reactions, we said this is the most common reaction, urticarial ones, anaphylactic reactions, transfusion-related acute lung injury, transfusion-associated circularity overload, graft versus host disease, post-transfusion purpura, and transfusion-related immune modulation. Most serious one, lung injury, TRALI. Febrile reaction, white cell or platelet sensitization, increase in temperature without any evidence of hemolysis. It's not very common, but usually people with history of repeated transfusions with repeated febrile reactions, we eradicate the white blood cells. We call it leukoreduced transfusions. Urticarial reactions, just a rash, hives, or erythema without any other symptoms. Sensitization of the patient to the plasma proteins mainly. Antihistamines with or without steroids should be enough. Anaphylactic reactions, severe, most commonly due to IgA deficiency patients given IgA antibodies. IgA deficient patients who have IgA antibodies given blood with IgA. This is the most common one, but it's not the only one. Reactions will require such as any anaphylaxis, epinephrine, fluids, steroids, antihistamines. Afterwards, we do a washing, washed packed RBCs or IgA-free blood units. TRALI. Patient will present within 6 hours of the transfusion with hypoxia, non-cardiac pulmonary edema, especially if we've given platelets and fresh frozen plasma, especially if we're doing a massive transfusion. It might resolve within a few days of support, but also it's the leading cause of transfusion-related deaths. So, might resolve, might not. Has TRALI usually markedly declined when we started to do HLA antibodies in the donor plasma, the principle of as a TRALI risk factor. Overload, blood products are administered at rates greater than the cardiac output. Usually happens in trauma resuscitation without considering whether the bleeding source has stopped or not. How to avoid that? There's a theory or association said, one of the association's regulations, that don't give blood if you don't need it. Even if you bring 4 units of blood because you have a massive bleeding, give one by one and assess. And then you can decide if you need to give the other one or not. And this is to avoid as much complications as possible. A thrombocytopenic disorder, post-transfusion purpura, blood or platelet transfusion results in the development of platelet alloantibodies. Platelets are actually very allogenic. So that's why most of us anesthetists try to avoid that as much as possible, transfusing platelets unless really needed. The platelet count drops within the next 5 to 10 days following the transfusion. We give them IVIG and plasmapheresis. Infectious diseases. We have hepatitis B and C. This is very rare, hepatitis C. Due to the screening nowadays, in the developed countries, I think it dropped to 1 in 100,000 or 1 in a million. In the third world countries, I think in Africa, I saw the range the other day, there was around 2 in 1,000. So it's really dropping because of the screening that we're doing. But still a serious complication because this is really habilitating. Serious infection that might develop into cirrhosis and hepatocellular carcinoma afterwards. HIV, all blood is tested for all the antibodies, which will reduce the risk of HIV transfusion-transmitted HIV. Massive blood transfusion. We've already mentioned the definition. The need to transfuse a whole patient's total estimated blood within less than 24 hours or half of it within 1 hour. For adults, that's estimated about 10 to 20 units. The approach to massive transfusion, as I said, 1 to 1 to 1, packed RBCs, fresh frozen plasma, and platelets to avoid dilutional coagulopathies. The most common cause of non-surgical bleeding following massive blood transfusion is dilutional thrombocytopenia, which is caused by platelet loss out of the body and platelet dilution with the replaced RBCs and crystalloids. This is transient. The body needs a little bit of time to equilibrate, although clinically it might be significant, especially in surgical patients. Citrate toxicity. Where is this citrate? Where does it come from with blood transfusion? It's the preservatives within the packed RBC's bags. Once it gets in, it attaches to the calcium. And usually, it's mainly metabolized by the liver. Patients with hepatic diseases or dysfunction are unable to metabolize it. Otherwise, usually normal patients can cope with transfusion unless we're giving 1 unit every 5 minutes. Normal patients can cope with this amount of citrate. We rarely give intravenous calcium unless we have liver diseases or calcium deficiency for any other reason. Hypothermia. It's mandatory to warm all your blood products to prevent hypothermia in your patients because hypothermia itself is a cause of coagulopathy. So you don't want to increase what you're already suffering from, so you need to warm everything up to avoid hypothermia. We nowadays have rapid infusing devices with efficient heat transfer capability that we use to warm all the blood before giving. Acid-base balance. What are you expecting with massive transfusions, acidosis or alkalosis?
Acidosis.
Now we have, within the stored blood, we have acetic acid and citric acid, but both of them, it's not accumulated, it's actually metabolized into bicarbonate, so you will have alkalosis by the liver. But you never know. With massive transfusions, acid-base balance status largely dependent on the tissue perfusion, rate of transfusion, citrate metabolism. And the accumulation, usually the blood bag itself will be acidic because of the metabolic products of the RBCs itself and the presence of acetic acid and citric acid. But once in the body, this will change. Hyperkalemia. Extracellular concentrations are usually high within the blood bags, and it's higher the longer time the bag has been stored. The amount of extracellular potassium transfused is at least typically less than 4 milliequivalent per unit, but hyperkalemia is definitely there if we're infusing at very quick rates, more than 100 mils per minute. أي سؤال؟ بريك
لا لا